Okay, and welcome to the Davies Use Case webinar being presented by Children's Hospital Colorado on Triple Aim for Children with Medical Complexity. This is a Davies Award-winning use case for the value of health IT. My name is Arnold Simmons. I'm the Manager of Quality and Patient Safety at HIMSS. It's my pleasure to moderate this presentation. Core to the HIMSS mission is promoting the use of health information and technology to improve the quality of healthcare delivery. HIMSS promotes and advocates the integration of clinical decision support and best practice guidance, access to clinical data to analyze progress, and information and technology enable patient safety tools for all healthcare organizations, clinicians, patients, and community members as vehicles for improving patient outcomes. The HIMSS Nicholas E. Davies Award of Excellence is a pinnacle of the HIMSS Value Recognition Program. The Davies Award recognizes outstanding achievement of organizations from around the world who have utilized health information and technology to improve patient outcomes and value. The Davies Awards winning use cases have been peer-reviewed to validate sustainable, improved patient and business outcomes resulting from health information and technology-enabled care delivery. So it's my pleasure to welcome our speakers for today, Dr. Christopher Still and Sarah Martin from Children's Hospital. Dr. Still and Sarah, I will turn the presentation over to you. Thank you.
Great. Thank you very much, Arnold. My name is Chris Stilla. I'm a general pediatrician at Children's Hospital Colorado, and presenting today with Sarah Martin, who helped greatly in putting this whole project together, including data and analysis. Caring for kids with medical complexity is just as complex as the conditions of the kids themselves. We have tried to make this process more streamlined and easier through a 3-year project that we undertook from 2015 through the end of 2017. This project involved several components. One of the components is getting to know who the children are. The other is putting care plans together for families. And the third is coordinating care using those care plans. I'll go through the steps that were involved in this project as well as the results that we got. On a national level, children with medical complexity comprise a small but significant number of children, about 6% of children nationwide, and that's remarkably consistent from hospital to hospital. Using the CRG scores, the CRG categories of 5B through 9, this also correlates to about 6% of children nationally. At Children's Colorado, there are about a little over 38,000 children who we care for in this category, and their spending just in the hospital is almost $650 million a year, so they're a very significant population. We participated in a learning collaborative, a national learning collaborative that I'll talk about more in a minute, called the CARE Project, Coordinating All Resources Effectively. We identified a subset of these children, which were about 1,600 of the most medically complex children, which have a total spending of about $73 million a year, which is very significant as well. Our goal was to coordinate care better for the small subset of children to demonstrate improvements in utilization, family experience, and cost. The CARE Award was, as I mentioned, a national collaborative with 10 children's hospitals, funded by a grant from the Centers for Medicaid and Medicare Innovation, and great collaboration with the Children's Hospital Association. Here you can see the different hospitals that participated, all leading children's hospitals nationally, that shared the problem of coordinating care for children with medical complexity better. The overall goals of the project were to improve health outcomes, including family experience for children with medical complexity, improving family satisfaction with access to care, and decreasing cost. The organization of the CARE Award had a lot of partners. In the middle, you'll see the part that was grant funded. There were some physician leaders, including myself. Each team had a lead care coordinator that worked with care coordinators through the practices that they worked with, a research data analyst, a process improvement expert, and most importantly, a family and social work liaison that helped create connections with both the families in the project and also the practices with whom we worked. On the left, you can see that each hospital had community primary care partners. There were local primary care practices that participated, behavioral health to the extent that was available, practices that had family navigators, involved them in the award, and there was a nurse care coordinator at each practice. Each hospital also, on the right, provided a lot of in-kind support for the project. At Children's Colorado, we had experts in process improvement, project management, health literacy to translate the care plans into versions that were parent-friendly, case management, also called care coordination, social work, primary care leadership, and electronic health record analysis to give us the data that we needed. As with any learning collaborative, there was a change package. The critical high-level elements of the change package were a patient registry, so we knew which children we were working with. Each child had a care team, and complex kids have large care teams, maybe between 3 and 10 partners. Identifying that care team was an essential part of the change package, because the care team members then were identified within the access plan. The access plan is essentially the bare bones of a care plan about who to call when for what, when different things happened with child's complexity, and also contained contact information for all team members. The access plan became the core of a larger shared care plan developed between parents and care coordinators to identify and address the specific needs of the patient and family, to set short-term goals and long-term goals in addition to who was responsible for those goals, and more broadly, to just create a snapshot of each patient so that everyone on the dynamic care team knew a lot about the patient. The overall goals for the change package were to create a number of different components that were integrated with one another, that we'll talk about later, accessible to all members of the care team, including parents and primary care providers, and transparent, so people could tell what the ingredients were of the care plan and how it came to be. Before the change package was implemented, we did some interviews with different team members, and they reflected the need for much better coordination and communication. Parents felt that different team members didn't always know what was going on with their child at any given time. Care coordinators couldn't find the information that they needed at the point of care, so it took them much longer to do their job. They didn't know who to focus on first. Who were the kids that were the most complicated, that needed care plans made before other kids? The net result of that was parents doing all of the care coordination for their own child, which we hear of a lot in national studies. And community primary care providers were a little bit lost because they didn't know who to contact for what, just like parents when they needed help. We started by getting some baseline data about our key determinants. We measured family experience using the CAPS patient and parent access module to look at access to appropriate care. We looked at utilization, specifically emergency department visits and hospitalizations, both frequency of hospitalization and inpatient days. And then we also looked at the total direct cost of care from hospital to hospital. As you can see in the table, our baseline CAPS normed on a 0 to 100 scale was about 69, so okay, but plenty of room for improvement to get to 100. Our patients, you can see, were quite complicated. The baseline utilization in the year before the collaborative started per 1,000 patients per month was 297 days. Emergency room visits were about 80 visits per 1,000 patients per month, which interestingly enough was lower than many of the hospitals in the collaborative. We already had a fairly robust complex care program in place, but we're looking to improve it even more. And the total direct cost was almost $16,000 per patient, reflecting the complexity of the patients in the collaborative. So our approach to this complicated problem was step-by-step. Started with definitions of who were the patients, designing a registry, putting into place a complexity score that Sarah and I will talk about in a few minutes to identify the patients with the highest level of care coordination needs to allocate resources for those patients. Step 2 was defining the needs, taking the complexity score and going through a couple of intensive Kaizen events that Sarah will describe about what resources went with what complexity score tiers. We also refined the complexity algorithm to utilize more than just diagnosis data, which was contained in the CRGs, to include psychosocial screener data and a number of other elements that we'll discuss. The third step was taking all that and defining some technology requirements to put together the care plans and make them available to all team members and integrate those into the electronic health record. Step 4 was actually to do that integration, to finalize the clinical tools and start to put them into use, streamlining the processes to really cut down the time it took for care coordinators to develop care plans and put them into the EHR. And then the fifth, finally, was to put the tools into practice, share them with parents, and use them for care coordination and improved care processes. I'm going to turn it over to Sarah now, who will talk a little bit more about the process by which all of this got started.
Hi, thanks for giving me the opportunity to present today. My name is Sarah Martin. I am a registered nurse, process improvement lead, and electronic health record analyst here at Children's Colorado. So like Chris said, our first big task was to define our patient population. In order to efficiently accomplish that, we held a 3-day Kaizen event with the Children's Colorado team. This was an 8-hour per day event, so lots of people in one room for a long time. The entire interdisciplinary team was included, and the result was a 4-tiered model of care that included both medical and social complexity elements. And this image is what things look like at the end of the 3 days. So I'll talk a little bit more about the details in the next slides. In order to get the scoring tool into the medical record, we of course needed an algorithm in order to do that. So this process map shows high-level elements of the scoring logic that went into the algorithm that was to be placed in the medical record. It starts by applying medical complexity elements up top in the blue section, including the 3M CRG, or Clinical Risk Groupers software, which I'll detail later. Next, we incorporated social determinants of health, including our own internal social screen, some standardized depression screens, and select adolescent risk screens. The complexity score then was to assign logic that's embedded behind the scenes to assign the score. Interventions and clinical decision support tools are applied depending on the assigned score that was assigned by the electronic medical record. This slide just represents our initial IT gap analysis of the technology components needed to generate the score and the interventions. You can quickly see here that we were missing quite a few elements compared to the right and left sides of that slide. More importantly, what we were really missing was that one transparent place that allowed our clinicians and families to find all the information that we needed there at the bottom. So we got very busy very, very quickly. The first piece that we incorporated was the Clinical Risk Grouper software. It's a proprietary patient classification system that uses DRGs, place of service, and pharmaceutical data to assign severity-adjusted risk categories. The output is a 5-digit score. It includes 9 categories where complexity increases with the number. So a CRG of 1 at the bottom of the pyramid there represents a healthy patient, whereas 9 at the top in red represents the most complex. On the right side, you can see the column that the clinicians will see in the health record that allows them to see what their CRG is for that specific patient. And although the CRG is a measure of medical and behavioral health complexity, it doesn't take into account the social determinants that we know apply to the majority of our pediatric patients. We developed and integrated a 15-question social screen into our medical record, focusing on the domains that you see here on the right-hand side of the slide. We added to that several standardized screens that you can see in the table below, and this really helped our clinicians to get a much better picture of the full complexity of the patient. A lot of people are wondering how that process looks, how we have patients enter a lot of social determinant data into the health record. So our current process for administering those screens does vary across the organization as we're rolling this out to lots of different areas in our organization. Some are still on paper, and some are answered through our patient portal the parent can access from their phones or from their computer. This slide shows our most common process. Our MA will hand the family a paper screen in the waiting room at their well care visits. The parent or that adolescent completes that screen in private, and then the provider will review the answers with them during their visit. If anything very critical comes up during the visit, the provider can then call in the needed resources right there in the clinical visit if they need the social worker or, say, a psychologist to intervene immediately with that parent or adolescent. The MA will then enter that information into the medical record, and any less critical needs, such as helping find a primary care physician for the parent or maybe some transportation challenges the parent may be having, can be followed up on after the visit by community health workers. Clinical decision support tools also will alert these clinicians who needs to help with what and be able to track the progress of taking care of those needs in the background. So here's an example of what two of those CDS tools look like for clinicians that are interacting with the medical record. The first one up top is an example of what an in-basket message would look like for a clinician that needs to follow up with a family that endures depression or anxiety. The second alert appears if a family had endorsed potential family safety concerns. You can see this one's a little bit more invasive. Rather than firing in the background, this one does pop up and disrupts the clinician's workflow in order to have them take immediate attention to take care of this family. Two things to mention about this tool: it does adjust the complexity when these social elements appear based on the parent's response, and it can go up or down depending on the endorsement that the family gives. And then in addition, these responses are time-bound, so it allows old problems to not continue on the patient's complexity score for an unneeded amount of time. So once we were able to build all of those previous slides into the medical record, which took quite a bit of time, as you can imagine, we added all of those elements to our general wellness registry. That allowed us to stratify our entire patient population, and you can see here exactly which elements we decided to include that would increase the complexity of the patient and in which order, in addition to the CRG. So the CRG alone, we determined, was not quite enough to stratify these patients appropriately. So because our registry includes kids seen in the last 3 years throughout our organization, we noticed that that CRG, like I said, didn't work quite perfectly for some of our sicker pediatric patients. And because of that, we added 3 specific criteria to increase those children to a Tier 4. You can see those up top. Those were home ventilation through a tracheostomy, kids on home TPN, and kids with a history of bone marrow transplant. Complex home care needs were also not always captured appropriately by that CRG. So things like Metaports, tunneled catheters, and G-tubes, we determined would bump those children up to a Tier 3. Social needs either increased kids to a Tier 2 or Tier 3, depending on the severity and complexity of that social need. And then healthy kids with acute illnesses like broken bones or maybe tonsillectomy remained there in the Tier 1. So backing up a little bit, 3 of our main technological goals, if you remember from earlier in the presentation, were that the information was integrated into the health record, accessible to anyone that needs it, including our parents, providers that may be based in a school-based program, or our primary care physicians, and then it was transparently available to all of those same people. So longitudinal plan of care that you see here was our solution to providing those technological goals. The view that you're seeing here is the ambulatory clinician schedule with the report below their schedule. Up top, you can see that clinicians can choose which columns they want to see, depending on their own view and what their preferences are. So this specific view, you're seeing the overall complexity score, the CRG score that applied to that patient, and whether or not the child had a positive social screen. Number two, that print group that says patient complexity score in the bottom left-hand corner, this allows them to have an idea of the complexity elements for that specific patient. And then the psychosocial screen in button number 3 allows them to see exactly which social elements were positive for that patient. I'm going to turn this over to Dr. Stilla so he can talk a little bit about how he uses this report in clinic.
Thanks, Sarah. As an outpatient primary care and complex care clinician, this is a very useful tool to use at the point of care with parents as well as with other team members. Many times when I see my schedule at the beginning of the session, for example, what I might look at is the complexity score of the different patients I'm about to see. You can see that if this were my schedule, I would have one level 2 complexity patient, 4 level 3 complexity patients, and 2 level 4 complexity patients, meaning I was in for a long afternoon. One thing that can help with this ahead of time is to look with the nurse and other team members on the team to be able to anticipate over time what the afternoon or morning might look like. If there's a patient with a lot of complexity, for example, the level 4 patient second, the team can anticipate as soon as they get there that they can start to work with the family while I'm in with my first patient. That way, care processes can be more efficient and families can get out on time with less waiting. Additionally, I can look at what went into the patient complexity score. For example, this patient, level 3 patient, has had different therapies, had some social determinants of health, did have recent screening for suicide and substance abuse, and so that we might need to do those screens. But for example, I might need to get the social worker together with the team to look at their social determinants risk. This makes visits easier, it makes sessions a little bit less stressful, and makes everyone able to sort of cope with a very complicated bunch of patients. You can see that this is also available to inpatient providers with the ingredients of the patient complexity score here as well. This helps to integrate into inpatient and outpatient care to some degree, especially at the care coordinator level, where there's a lot of risk involved in discharging patients with different levels of complexity so that the care coordinators can work with one another. Again, all of these elements are integrated within the EHR so that everybody that has access to that can get access to this patient complexity score. This is a little bit of broader look at what the access plan and care plan look like to care providers, and then we'll have another look on the next slide of what it looks like to patients and families. As you can see on the left is the dynamic care team. Who are the different care team members? Primary care provider, maybe more than one, a psychiatry resident, a nursing care coordinator, a couple of other consultants. The notes are what the care coordinators put in, which is essentially a summary of who am I of the patient, some highlights, enjoys his smile and laughter, likes to ride his bike and scooter, things like that, things that may not be medical but can give the care team a fuller picture of what patients are like. Below that is some of the goals that are made with the patient and care team and family. This patient has about 5 or 6 different goals and different kinds of therapies that are ongoing. And then finally, the access plan, which is who to call when for what. Parents found this to be the most useful part of the care plan because if their child is sick or in an emergency, it's very simple and easy to figure out who to call when, which was previously much more difficult for families to figure out. This view is available also to community providers and home care companies in the school through the web portals that they're able to get into REHR. This is the parent view of a longitudinal plan of care, a little bit more simplified view of what was on the last slide, but still has who's on their care team, how to get in touch with them, the access plan, and then some other information about their phone numbers for their care team. So we implemented this over about a 1.5 to 2 year period in 2015 through the first part of 2017, and we got, fortunately, some pretty good results. At the high level, as you remember from the CARE project, the major outcomes were patient experience of care, care processes, some care outcomes, and then cost. As far as patient access went, our baseline rate, if you recall, was 69 out of 100. That rate, as determined by parents, went up to 81, which was a 16% change, which was statistically significant and more than the collaborative was as a whole. I'll have that in a couple of slides. Inpatient days decreased dramatically by a little over half. The collaborative goal was ambitious at 40%, but we managed to exceed that anyway. ED visits also decreased from a relatively low baseline of 80 visits per 1,000 patients per month to only 54 visits, which was a decrease of almost a third, again exceeding the collaborative goal of 10%. Not surprisingly, given that these are high-cost utilization measures, direct costs to the hospital also decreased by almost 40%. The collaborative goal was just about 7%. This slide describes the process of implementation of the different parts of the change package. The yellow line is dynamic care team identification. The red line is access plan implementation for patients, who to call when for what, again sort of a stripped down version of a full care plan. And then as you can see, the blue line is how many patients got a full care plan. This was a much slower process because it involved significant care coordinator time. After the package was put into place, we did some interviews with patients and families, care coordinators, primary care providers, and you can see that they were quite positive. Parents knew where to go for care, the access plan for who to call when for what was working. Care coordinators felt that the information that they needed was now in one place instead of many places, and they can prioritize by seeing who their more complex patients were for any given time. And community primary care providers felt that the access plan and the care team members being identified all in one place was really very helpful. This compares our hospital results to some of the other hospitals in the collaborative. You can see that patient access scores on the CAPS did go up significantly for the entire collaborative by about 2.5 points. Our hospital started a little bit lower, wound up a little bit higher, and was actually one of the leading hospitals in the collaborative in terms of improvement in patient access scores. As far as utilization goes, you can see that the decrease in utilization was significant and sustained during the period of the collaborative. The ups and downs that you could see correspond with seasonal variation in inpatient days and emergency department visits, not surprisingly. The decrease in inpatient days was more pronounced after the interventions were begun, as was the decrease in emergency department visits. Notably, the influenza season of 2017-2018 was one of the most severe since 2009, but the changes were able to be sustained through that severe flu season, which really is a testament to the durability and the effectiveness of the intervention. We also kept in mind that different parts of the change package, specifically the access plan, as you recall from a couple of slides ago, were implemented more slowly for different patients because of the resources that we were able to bring to bear at any given time. This slide looks at the relationship of one of our outcomes, ED visits, to the amount of the change package that was able to be put into place. So the elements of the access plan and the elements of the care plan per patient. You can see that there's a strong positive relationship between the number of change package elements per patient and the decrease in ED visits, saying that, telling us really that these changes, despite some time trends toward decreased utilization, were actually real during the course of the collaborative. Finally, here's a slide looking in a little bit more detail at direct costs and what really changed. As you can see, the inpatient costs dropped from 2015 to 2016 to 2017, reflecting the decrease in utilization. The other interesting thing, which has been observed in many other collaboratives nationally, is that outpatient costs actually rose a bit. This is not surprising, given that patients who were identified for care coordination received more outpatient services to meet their needs. The good thing was this was accompanied by a concomitant decrease in inpatient use and an overall decrease in cost. Finally, looking very closely at some of the most complex patients, it's a little bit of an open question whether the most complex patients are able to achieve decreased utilization and costs over time because of the complexity of their problems. These are kids who you expect to be admitted from time to time and whose problems can be very variable and severe. We concentrated on the Tier 4 patients for complete care plans, and this slide shows the slope of the line for Tier 4 patients with and without a care plan. The ones that did receive a full care plan did seem to have a steeper slope in their decrease of utilization over time. This needs to be evaluated using more data because this is a relatively small cohort of patients. But again, points toward the utility of the access plan in decreasing costs and utilization even for the most complex patients. So taking a step back and just thinking about the lessons that we learned through the collaborative and through our interventions, one thing was it was really, really important to get feedback from parents and the team during the process. Building this into the EHR was difficult, and given our resources, that our resources were limited, it was hard to know which children to intervene on first. Parents told us that the access plan was the most important out of the elements of the care plan, and care coordinators also told us that really getting to the most complex kids should be a priority. We learned that early in the collaborative, and we feel that that translated into more rapid improvement. Additionally, there's a lot of iterations of the building. It's important to kind of go step by step and see if the EHR build works at a lot of different times. And finally, integration of the social determinants of health, not just the medical complexity, was really important to identifying which kids needed which interventions at which times. So it was a hard process. Designing effective care coordination is still ongoing, and it's difficult but not impossible if you bring the whole team to bear. So in conclusion, through this package of interventions, we were able to decrease inpatient hospital days, ED visits, and total direct costs to the hospital in a population of medically complex children after care coordination interventions. Satisfaction as reflected in both qualitative quotes and satisfaction with access increased for both families and providers. And our next steps are to expand this to all the ambulatory clinics, not just some primary care and the complex care clinic, expanding social determinants of health screening to community practices, collaborating with health systems in our region to try to streamline shared care across the continuum of care, not just within the four walls of the hospital and affiliated primary care practices, and then to share these solutions with other health systems across the country, which we've already started doing. We'd like to thank our very large team with community practices, hospital leadership, care coordination, IT people, and parents to help us succeed in this collaborative. And thank you for listening to our presentation. I'll turn it back to Arnold.
Okay, thank you, Dr. Still and Sarah, for that great presentation. We would like to remind folks where to go find this recording and other great Davies use case recordings and information on how to apply for Davies. That information can be found at the HIMSS Davies website at hims.org/Davies. Once again, thank you very much.